Hello and welcome to another video. In this video, we're going to be going over microcytic anemias. So if you recall from the last video, we had mentioned that microcytic anemias are classified by having an MCV being less than 80. So how does the microcytosis occur? So essentially, in the creation of the red blood cells, right, you start off with an erythroblast. And this erythroblast undergoes several divisions, like you see here, until it eventually becomes a red blood cell. So with each division, it gets smaller and smaller and smaller. So the way that this happens is the microcytosis occurs because there's an extra division during this process. So, for example, if normally, right, you would have two divisions to create a red blood cell. There's an abnormality where instead of having these two divisions, you have one extra one, and so that's why the red blood cells come out smaller than they should. And this is because of a decreased production of hemoglobin. So the erythroblast will divide one extra time to maintain the concentration of the hemoglobin within the red blood cell. So, okay, another way of saying this is, okay, imagine each red blood cell having one hemoglobin in it. Okay, if we have a situation where we have decreased production of hemoglobin, so we don't have enough hemoglobin as we should in the body, right? That means that if we don't do something about that, we may have certain red blood cells that don't have hemoglobin in them. And that's a major problem. Because if you remember from last video, we need that hemoglobin to transfer oxygen throughout our body, right? And hemoglobin lives inside of our red blood cells. So we need the amount of hemoglobin to match the amount of red blood cells we have. Okay, so what does the body do in that case? To try and fix that problem, it's going to divide one extra time in order to maintain the concentration of hemoglobin and red blood cells to be adequate, so that we have enough red blood cells for enough hemoglobin. And this is what makes up hemoglobin over here. This would be helpful to understand, and it breaks down all the different types of anemia that we'll go over in this video and coming videos. But the first would be iron-deficiency anemia. But before we get into that, what is hemoglobin? What makes hemoglobin? How do we get there? So to make hemoglobin, we need two things. We need heme and we need globin. Okay? And the way we get heme is with iron and something called protoporphyrin. And so we'll get into more detail on all these different factors and things. But essentially, if you have any issue here, your hemoglobin goes down. So if we have less heme, we don't have enough heme to combine with the globin, our hemoglobin is going to go down. If we don't have enough iron, we don't have enough iron to bind with protoporphyrin to make heme. Thus, we have less heme. We can't make as much hemoglobin, etc. So you can see how anything that's going to be affecting the levels of any of these different molecules is going to reduce our hemoglobin and cause a anemia. So the first type of microcytic anemia we're going to go over is iron-deficiency anemia, or IDA. And this one's probably the easiest, I think. And that's just because it tells you in the name exactly what it is. It's like in your face, iron deficiency. So this is commonly seen in vegans, or just people that maybe have heavy menstrual cycles, or maybe you're not vegan, but you just don't eat a lot of red meat or stuff like that. So iron in the F2 state is the most bioavailable. That is to say that iron needs to be in a certain form for your body to absorb it and use it, and that form is Fe2. And animal proteins like red meat is is the most common because that has the most concentration of iron, is in the Fe2 form. There's iron found in vegetables, but it is in the Fe3 form. So that's why it's very commonly seen in vegetarians, vegans, where they're not eating animal proteins. They may have iron deficiency anemia because they're consuming a lot of iron, but it's in the Fe3 state, so your body can't use it. And this is what you want. You want your Fe2, and your body will convert some of this Fe3 into Fe2 to use it, but it's not very efficient. So, long term, if you're strictly eating vegetables, you will have a deficiency in your iron. So to create heme, right, we need iron, like we said before. So iron's absorbed in the duodenum, which is one of the sections of your small intestine. So once the food goes through your stomach, it'll go into the small intestine, and the duodenum is where the iron's going to be absorbed. So ferroportin is actually a key regulator in that process. So here's a little drawing that I did to try and explain that. So if you would imagine these little squares I drew to be the enterocytes, the cells in the duodenum, this being the lumen of the gut, where the food is passing through, and then this being the other side of the cell wall where the blood vessel is. So you have food here on the side. Your gut, or your duodenum specifically, right? The enterocytes are going to absorb the iron, and they're going to pass it through the blood, and then you can be able to use it, right? And one key regulator is ferroportin. So ferroportin is going to decide if iron gets absorbed into the blood or if it stays here. And so ferroportin is also very important when thinking about iron deficiency anemia. Iron must always be bound to prevent free radicals. So iron normally is always going to be found bound to something, otherwise it's going to cause issues. So in the blood, iron is bound to something called transferrin, and transferrin, all that does is transport iron from bone marrow macrophages for storage, as well as to the liver. And I like the word transferrin because it sounds like exactly what you would think it does. It transports iron. In the liver, iron is bound to something called ferritin. So ferritin is what's going to help store the iron. Transferrin is going to help transfer the iron. So here we have an image, right, depicting blood vessel. Here, when iron is transferring in the blood vessel, remember, iron can never be alone. It has to be bound to something. Think of it as a clingy friend. Iron is a very clingy friend. He always needs to be with somebody, right? Holding somebody's hand. So that's transferrin. Transferrin in the blood vessel is going to be bound to iron because it's transferring iron to wherever it needs to go. And so we can measure serum iron to know how much iron there is. And we can use something called the TIBC to measure how much transferrin there is. Because remember, if we know how much transferrin there is, then we indirectly know how much iron there is, because iron in the blood has to be bound to transferrin. So these are different markers, right, we can look at. So we talked about serum iron. We can measure how much iron there is. We can measure with the TIBC how much transferrin there is. And then we can look at something called percent saturation. And percent saturation is going to let us know how much iron is there that is bound to transferrin. Okay. And ferritin is going to be found in the liver and in the macrophages because, like we said before, iron is bound to ferritin when it's in the storage phase. So we can also measure ferritin in the blood to know how much iron is in storage. So this all gives us a better idea to try and pinpoint exactly what the problem is and how can we fix it. I'd mentioned being vegan, vegetarian, that kind of thing, that can cause iron deficiency anemia. Some other things that can cause it are things like celiac disease. So you have not enough absorption in the duodenum of iron. So you don't really have an issue of intake. You're consuming enough iron, you're eating, animal proteins, that kind of thing. But you just can't absorb it. And then you can also have patients that may have a gastrectomy where they lose part of their stomach, for example. And so now they have less acidity in the stomach. And now you have Fe3 that is going to be more common than Fe2. And there's many different reasons. So now we go into the stages of iron deficiency. So the first stage of iron deficiency is going to be your body's going to use up its storage. That makes sense, right? When you run out of something, first thing you do is, okay, let me go check the pantry. Let me go see what I have in storage, right? So that's what your body's going to do. Your body's going to use up the storage. And so you would expect your serum ferritin to decrease, because remember, your ferritin is where iron is going to be bound in the storage form. So if we're starting to use our storage, we can expect serum ferritin to decrease. And always, 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 you can expect your TIBC to do the opposite. So if ferritin is decreasing, our TIBC is going to increase, and that, remember, is the measure of how much transferrin there is. And that makes sense, right? If we're decreasing our ferritin, right, which means that we are storing less iron, we're using it, we need to transport the iron, right, throughout the blood to take it where we need to take it so we can use it. And that's why we're going to see transferrin increase. So our ferritin decreases, our TIBC always does the opposite. It's going to increase in this case. Then the second stage of iron deficiency anemia is your serum iron being consumed. So now we've used up our storage. Now we're using everything that we have available that's attached to transferrin. So now our serum iron decreases, and we can expect our percent saturation to decrease, which, if we remember, is the measure of how much iron is bound to transferrin. So if we're using the iron that is in our serum, right, we know it has to be bound to transferrin. So we know this complex, iron transferrin complex, right, we can call it, that's our percent saturation. It decreases because we're using it. And so this is no longer as available as it used to be because we're breaking this bond and we're using this iron. So that makes sense why our percent saturation decreases. And here's an example. If we're looking at percent saturation, right, normal would be about 33%. That's you would see in a lab. So if, just to simplify it, if you would imagine we have 6 transferrin molecules, on average, you would have 2 of those transferrin molecules being bound to an iron. And so that's why our normal value is about 33%. But if we have the iron that's being used up, if we're using all this iron up, you can expect that percentage to go down because now we don't have enough iron, or as much iron as we did before, to bound. We don't have as much iron as we did before to bind to the transferrin. So now instead of it being 33%, we could say maybe in this example, it's at 16%. And the next stage of iron deficiency is actually normocytic anemia. So we're still talking about microcytic anemia, but in the process of this microcytic anemia, the patient will present with normocytic anemia. And the reason is because the bone marrow settles by making less red blood cells because of the lack of iron available to make hemoglobin. And the bone marrow wants good quality red blood cells. That's why it does that. So we've used up iron storage. We've used up the iron we have in our serum. We're really low on iron. Okay. So the body's like, well, we don't have enough iron. I can't make good quality hemoglobin and good quality red blood cells. So I'm going to settle by just making less red blood cells because our hemoglobin's low. And if you remember the last video, we talked a little bit about how you want, one of the ways we measure anemia, basic definition of anemia is looking at hemoglobin. And that's because every red blood cell has hemoglobin in it. So this also makes sense because if we don't have enough hemoglobin, right? Because we don't have enough iron to make it. Well, unless we decrease the amount of red blood cells we have, we're gonna have a problem where we're not matching the amount of hemoglobin and red blood cells that we have. And so that's why your bone marrow is going to settle to try and fix that issue by making less red blood cells. And then the last stage of iron deficiency is finally going to be your microcytic anemia. And that is along with what we call hypochromic anemia. And that just means that there's less color and a larger central pallor with microcytic hypochromic anemia. And you can see that under the microscope. So normally the red blood cell will have a small central pallor like this. So this will all be red, and the center will be a little bit less red. It'll be a little more clear. But in this case, instead of it having a small central pallor, it's going to have a much larger one. So now all of this is red. Some specific signs and symptoms we can see with microcytic anemia would be pica, like we said before in our first anemia video, and something called koilonychia, if I pronounced that correctly. And that's a fancy word for spoon-shaped nails. So those symptoms can lead you in the direction of iron deficiency anemia. And the treatment for these patients, of course, is iron supplementation, but you want to rule out carcinomas first. We can also measure something called free erythrocyte protoporphyrin. Because like we said before, protoporphyrin is bound to iron. And if protoporphyrin is elevated because there's not enough iron to bind to it, that can also be another way we can diagnose someone with iron deficiency anemia. The next type of microcytic anemia is anemia of chronic disease. So anemia of chronic disease is due to chronic inflammation. And hepcidin is going to be a molecule that's sequestering iron in storage sites and limits iron transfer from macrophages to erythroid precursors. So your hemoglobin's low, your hemoglobin's low, and you have microcytic anemia. And this is also going to suppress EPO production. So here is an example of how that works. So your body, in the case of chronic disease and having chronic inflammation, your body is responding as if you had a bacterial infection. So that's why it's reacting this way, because bacteria require iron to function. And so the body thinks that bacteria is present, and that's what's causing the chronic inflammation, right? Instead of, whatever it is, like maybe, chronic kidney disease. But your body's thinking, oh, this guy's just got chronic inflammation because he's infested with bacteria. So what are we going to do? We're going to activate hepcidin to sequester the iron in storage sites so that the bacteria die off and can't use the iron. And if you remember ferritin, right, from previous slide, ferritin is what's storing the iron in your liver and your macrophage, bone marrow macrophages, and your transferrin is what's going to be transferring the iron in the blood. Hepcidin is going to sequester that iron so that it can't be used. And these are the lab values that we would expect to see with somebody that has chronic disease, chronic inflammation, and anemia. So your ferritin's going to be elevated. That makes sense, right? Because we're storing more of it because our body thinks that we're infested with bacteria. It wants to kill off that bacteria. Bacteria require iron. So let's sequester it using hepcidin and ferritin. So our ferritin is going to increase. And like we had mentioned before, if whatever ferritin does, TIBC does the opposite. So if our ferritin is increased, our TIBC is going to decrease. And that is letting us know that there's less transferrin because we're not needing it to transfer iron because we're storing it. Our serum iron, of course, is going to be decreased because we're storing it more, so we're not going to find it in the blood at high levels. Our percent saturation is going to decrease because, again, this complex of iron and transferrin is going to be low, and our FEP is going to be elevated, which, if you remember down here, the free erythrocyte protoporphyrin. So this is measuring our protoporphyrin. That is going to be elevated because we don't have enough iron to be bound to it because we're storing it all. And so the treatment in this case would be treating the chronic disease is the only cure. In cancer patients, we can also try EPO. Sometimes in renal patients, we could try EPO as well to try and promote better function of this process, right? Because EPO is going to suppress hepcidin. So a lot of times we can supplement with EPO injections to try and suppress hepcidin, sequestering the iron, and that may help get it out of storage so we can get it bound to transferrin and try and resolve the anemia. But the real only treatment would be trying to cure the chronic disease, or at least control it. The next type of microcytic anemia is called sideroblastic anemia, and this is a problem with protoporphyrin. We're not forming enough protoporphyrin. There's some kind of defect in the synthesis of protoporphyrin, and thus we can't make heme, and heme can't bind to globin, and we can't make hemoglobin. And so we're anemic, right, by definition. This is a shortened version of how we get to protoporphyrin and heme and all that kind of stuff. So we start off with a molecule called succinyl-CoA. ALAS is going to be the rate-limiting step here. That's going to be the enzyme. And vitamin B6 is going to be the cofactor for ALAS, right? And that's going to make ALA. And then the next enzyme we're going to use to convert ALA to something called porphobilinogen is going to be ALAD. And then there's a series of reactions, a bunch of stuff that goes on. And then in the mitochondria of the red blood cell is where we're going to have protoporphyrin be formed. Okay. Now, where does the iron come from? The iron's going to come from storage. So it's in ferritin. Then you're going to have transferrin come, transfer that iron. And then you're going to have something called ferrochelatase that's going to link them together. So ferrochelatase is going to link protoporphyrin and iron together so that you can make heme. Okay. Now, this is where the problem is with sideroblastic anemia. It's a congenital defect, right? That's the most common type. And so you have a problem with ALAS. And that prevents succinyl-CoA from, forming ALA and then eventually forming that protoporphyrin. There are also other reasons why you may have sideroblastic anemia. One of them being alcoholism, because it's literally poisoning your mitochondria. And remember, this step right here occurs in the mitochondria. So if your mitochondria is messed up, protoporphyrin in the mitochondria is going to be messed up. Lead poisoning, because lead denatures ALAD and ferrochelatase. So if you have lead poisoning, this enzyme right here is not going to work, so you can't form this. And ferrochelatase is not going to work, so you can't link protoporphyrin and iron together. And then lastly, a vitamin B6 deficiency. Because if you remember, that's an important cofactor in this process right here. And so you can't make protoporphyrin. And you could have vitamin B6 deficiency if you're having, vegetarian, vegan diets, stuff like that, more common, very nutrient deficient, or even with alcoholics. They're usually pretty low on certain nutrients, vitamin B6 being one of them. However, a medication that could cause vitamin B6 deficiency is isoniazid. So if you have a patient with isoniazid, or if that's mentioned in the question stem, a patient, is taking isoniazid, but, they're presenting with anemic symptoms. So they have fatigue, maybe they have some pica, whatever it is. Maybe they even show you this picture right here. You may think about, okay, they may be deficient in vitamin B6. That's a cofactor, and I'm thinking sideroblastic anemia. And so this picture right here is actually showing us what you would see in a blood smear. So this is what sideroblastic anemia would look like under the microscope. And these little blue dots in the red blood cells are iron that's trapped in the mitochondria. And you have an iron overload. Why? Because we're not forming protoporphyrin. So iron is just floating around freely because there's no protoporphyrin being made. And so that's why you have all these blue dots. You can actually see the iron overload in those red blood cells in the mitochondria specifically. And excess iron, remember, like we said before, if iron is not bound to anything, it forms free radicals. So excess iron is causing free radicals, and these cells can actually burst, and the iron is going to leak out. And what happens is then you have the bone marrow macrophages that are going to eat up all this iron because they're trying to write the cleanup crew. They know it doesn't belong there. And what does this cause? This causes your ferritin to increase and your TIBC to decrease. And then you have serum iron and percent saturation increasing, of course. So these are all things you would expect to see in sideroblastic anemia. And now, finally, lastly, we're getting into the thalassemias. These are also types of microcytic anemia. So we have alpha and beta thalassemia. But first, what is thalassemia? So thalassemia is where you have decreased synthesis of globin. So decreased synthesis of globin, we're thinking microcytic anemia. Those are the thalassemias. Protoporphyrin problem, we're thinking sideroblastic anemia. Iron problem, iron-deficiency anemia. We can't form heme with these problems. With thalassemia, however, heme is not the problem, it's globin. Because remember, you need both of them to form hemoglobin. So, this is an abnormality of the globin chain. And this would be a thalassemia, like we said before. So, if we did not have a problem in synthesis of the globin chain, if we have an abnormality of the globin chain, so we're making globin, but we're making it incorrectly, right? It's not coming out right. That would not be thalassemia. That would be sickle cell. So that's an important caveat. So thalassemia is a problem when we have decreased synthesis of globin. We're not making enough globin. But it is not an abnormality of globin. There's nothing wrong with the globin we're making. We're just not making enough of it. If the decrease in synthesis is alpha globin, we call it alpha thalassemia. And if it's a decrease in beta globin, we call it beta thalassemia. Easy enough. And these are all the different types of hemoglobin you see. Fetal hemoglobin you see in, the fetus and the first 6 months or so of life. It's the most common, hemoglobin F. And that's made up of 2 alpha, 2 gamma, hemoglobin A2, 2 alpha, 2 delta, and then the most common, hemoglobin A, that's the normal kind for adults, 2 alpha, 2 beta chains. And so these are your globin chains that make up the hemoglobin. Because hemoglobin is made up of 4 globin chains, 2 alpha, 2 beta. But in alpha thalassemia, we have a problem with these alpha globin chains. And this is a gene deletion on chromosome 16, actually. So if these were your chromosomes, if you had a gene deletion in just one of these spots, you'd be asymptomatic. You'd be fine. But if you had them in 2 areas, they could be on the same chromosome or on adjacent ones, you'd probably have a mild anemia. And we refer to it as trans or cis. So if it's opposite to each other, trans. If it's on the same side, it's cis. The trans type of alpha thalassemia more common in Africa. The cis type is going to be more common in Asia. And it's actually the worst type because since they're both on the same chromosome, they're more likely to be passed down entirely. And severe anemia would be if one of the chromosomes are completely shot, plus you have another one, right? And so in that case, that would be the worst case of alpha thalassemia. Problem here is that the beta chains are forming tetramers because alpha is unavailable. So, like we said before, you need 2 alpha and 2 beta. But if alpha is not available and the betas are just sitting around, well, they're going to bind to each other and they're going to form tetramers. And they form, instead of forming hemoglobin A, they form hemoglobin H. And that's where you have the issue. And your gamma chains can also form tetramers for the same reason, right? For fetal hemoglobin. Except instead of calling it hemoglobin H, we call it hemoglobin Bart's. And that's going to lead to hydrops fetalis, which is lethal in utero. And now finally, the last type of microcytic anemia would be beta thalassemia. And beta thalassemia is again due to a gene mutation, but in this case on chromosome 11 instead of 16. And you can have different kinds of mutations. You can have a mutation where the beta globin is completely absent, and we depict that by writing it this way, beta null. Or you can have a mutation where you have decreased production of globin, and that would be written like this, beta with the plus sign. And beta thalassemia is further broken down into minor and major. Major is exactly what it sounds like. It's worse than minor. And beta thalassemia minor would be where you have one of the beta globins completely absent, and the other one is just decreased in production. And this is the minor form of the disease. Patients here are usually asymptomatic, and you're going to see target cells on blood smear. And we call them target cells because they literally look like targets on blood smear. So you can see it here. You have a central area of pallor, and then in the middle, you have some more redness. And these patients are also said to be hyperchromic microcytic. And the key finding is going to be increase in hemoglobin A2, which, if we remember, is right here, 2 alpha and 2 delta. So if we have an increased amount of hemoglobin A2, where we have a lot of 2 delta present instead of the 2 beta, we're thinking beta thalassemia minor. Beta thalassemia major is actually not diagnosed until later on when you start getting symptoms. And the reason is because as soon as the baby's born, your fetal globin starts a slow transition into your adult hemoglobin A. But once your body recognizes, hey, we're beta null, we have absolutely no beta globin available, that's where you have severe beta thalassemia, and we call it major. And the alpha tetramers form because we have a lack of beta globin, and that's going to lead to extravascular hemolysis, which means that we're going to start destroying red blood cells. And it's also going to lead to something called extramedullary hematopoiesis, which means we're going to start forming red blood cells from areas that, as an adult, we normally would not. And for that reason, we're going to start seeing nucleated red blood cells. Essentially, they come out of the assembly line too early. And so they come out with a nucleus. And you have several symptoms, buzzwordy stuff for beta thalassemia major. One of them is going to be your chipmunk-like face due to the hematopoiesis in the marrow of the skull and the face. So normally, right, you wouldn't have that going on. So we're having the extramedullary hematopoiesis where we have increased hematopoiesis in the bone marrow, and skull, and the face, and then also liver and spleen later on. So that gives you that chipmunk-like face. And you're going to have something called crew-cut appearance on X-ray, which is what this looks like. This right here is not normal. Shouldn't see that on X-ray. And then we can even have something called aplastic crisis if it's with parvovirus B19. So why the aplastic crisis? So the patients, right, with beta thalassemia, they're extremely dependent on red blood cell formation because stores are low and production is ramped up tremendously, and that's what causes that aplastic crisis. Chronic transfusions are necessary, and that's going to lead to secondary hemochromatosis, which basically means you have too much iron from the transfusions. Because you got to remember, we're transfusing the patient with blood, so we're giving them blood, but along with that blood, there's a lot of iron coming in. So one way you can think about it is you're basically giving the patient bags of iron, and the body doesn't really have a great way of getting rid of that iron. So you're going to accumulate a lot of iron from these transfusions, and that's going to be problematic because now you have way too much. And of course, you have no hemoglobin A present, like we said before, because you're beta null. There's no beta globin available. So your hemoglobin A2 and your fetal hemoglobin is going to be elevated, and you're going to see the target cells like we saw before, and those red blood cells are going to be hyperchromic and microcytic. And that's all I have for you from microcytic anemia.